Friends of Indian Medical Association, we, the College of General Practitioners of IMA Kerala State, is extremely delighted to present our weekly webinar series on every Thursday from today. We are, we are in a few minutes, ahead of the program. Actually, there are some technical things getting arranged and people are just logging in, and we'll allow the logging in for a few more minutes, 1 or 2 minutes, and then we'll start the program immediately. So we request all of you to kindly bear with us. Meanwhile, let us not waste time. You all can, or rather you're all invited to share your views on this program. Which all topics will be of extreme usefulness for the every general practitioners across our nation. And then you may also suggest the faculties from whom you would like to listen to. You can use the chat box for the same.
Good evening.
Good evening, sir. Sir, start a moment, sir.
Yeah, please.
Thank you, sir. Thank you. Respected leaders and dear friends of Indian Medical Association across the nation. We, the IMA College of General Practitioners State Chapter of IMA Keralam, is extremely delighted to launch the weekly webinar series, Essentials of Every Day in Modern Medicine. See, as you all know, modern medicine is the corners, the heart of public health in India, or if not the world. And the heart of public health remains family medicine or general practitioners. Every doctor should be empowered in his or her general practice. And that is why there is the oldest wing of Indian Medical Association, oldest academic wing of Indian Medical Association, the College of General Practitioners. Friends, let's not waste our time. Let us start the program. And we have a big array of eminent leaders of Indian Medical Association with us today. Today being the inaugural day of the Essentials of Everyday in Modern Medicine by the College of General Practitioners, IMA Kerala State. Friends, at the outset, let me tell you, this is a program which will be conducted every Thursday via Zoom platform with the same Zoom ID, with same Zoom password and the same Zoom link. The meeting will also be live streamed through IMA Kerala official YouTube channel, www.youtube.com/IMA Kerala official, so that the recording will be available for future reference too. Now, the program is about to start. Let us start the program with a silent prayer. Thank you all. Now, we have with us eminent leaders of Indian Medical Association. Let me invite our beloved State President of Indian Medical Association, Kerala State, Dr. M.N. Menon, to address the gathering and inaugurate this weekly webinar series. Hearty welcome, sir. Menon, sir.
Yeah, very good evening. As already mentioned by Prasanth, we are going to academic wings, the CGP and AMS. As you know, I'm traveling and I will be very brief because there will be range problems. Okay.
Okay, sir.
Not a routine speech. So it's good that you have started the weekly series of webinars. And today I think the first speaker is Dr. Padmakumar, isn't it?
Yes, sir.
Yes. And we have eminent leaders of Indian Medical Association present here, like Ashokan sir, Pavindra sir, Patrapala sir. It is a good gathering. So instead of wasting much time, I just officially declare that this webinar series, which has been designed by Prasanth and the CGP, is officially inaugurated. And I hope there will be very fruitful interactions and enlightening session by our Padmakumar, right man for the job. He was the principal of Alleppey Medical College, if I have not mistaken. So all the best, Prasanth and team. I'll be listening. Thank you.
Thank you very much, sir. Now we have with us the National Vice President of IMA, Dr. Ramesh R. A hearty welcome, sir. Kindly address the gathering.
Thank you, Dr. Prasanth. Good evening, all leaders of IMA and all the esteemed members who are attending this all-important webinar. First, let me congratulate Dr. C V Prasanth for taking this great initiative to conduct a continuous series of continuing medical education through the web series, and it's going to do a lot of help to the medical professionals practicing modern medicine. As you all know, that medicine is evolving at an unprecedented pace, and newer emergence of techniques, diagnostic techniques, treatment techniques, and changing disease patterns. Everything is changing on day-to-day basis, and it is all important that we need to be updated on this medical education on a day-to-day basis. And on this account, I think IMA CGP chapter of Kerala State Branch, led by Dr. Prasanth, is doing a marvelous job. And I think this webinar or series of webinar will definitely help the members of a profession to upgrade their medical knowledge and their skills for a better practice. And it also helps the community too. So I'm also not taking much of your time because the session is more important. And today we have a very important session on history taking. Maybe we will go back to our third year class when we went for clinicals for the first time, and we knew what is history taking, and we learned about history taking. And even today, it is very relevant because even though we have a lot of technological advancement for diagnosis, but the history taking becomes a very crucial factor since not only aids in our diagnosis and further treatment, but also I think it is a very powerful medium for a very strong doctor-patient relationship. So I wish you all the best And Dr. Prasanth, keep going. So wish you all the best for the series of webinar. Thank you.
Thank you very much, sir. Your words are truly inspiring. Now, let me proudly invite the National Dean of IMA CGP, Dr. Shobha Ahuja, ma'am. Ma'am, your trajectory of victory, both in Indian Medical Association or in the national picture, is extremely amazing. We are so glad that you are a leader par excellence, and we are extremely delighted to have you here today on this this prestigious occasion. Hearty welcome, ma'am. Kindly address the gathering. Shobha, ma'am, kindly unmute and talk.
Okay. Sorry. Okay. Thank you very much, Dr. Prasanth, sir, and good evening to all of you. The National Past President, Dr. Ashokan, sir, Dr. Pillai, sir, the present State President, Dr. Ramesh, Dr. Ravindran, and of course, my colleague and friend, Dr. Amutha, ma'am. A very hearty congratulations to you. See, talking and doing, there is a lot of difference. What you are doing, Dr. Prasanth, is you are putting into action whatever you have thought of, and that is for the welfare and for the good of the community. I would like to take just 2 minutes, if you don't mind. See, there are about 4 lakhs of members of IMA, but how many CGP members are there? There are only 25,000 to 26,000. IMA member, all of them are MBBS. So there should be more CGP members. So I request the Keralam to please see to it that you increase the CGP number. And how much you have to pay for it? Just one-time payment of not more than 1,200. So it is very necessary that the strength of CGP should increase. I also bring greetings from IMA CGP headquarters. What I would like to tell you is that family physician is a first contact in medical emergency, but he has been upgraded by IMA CGP by introducing many certificate and fellowship courses in non-communicable diseases, in 2D echo, USG, family medicine, medical ethics, that would update any family physician's knowledge as well as give them more confidence, more safety. The medical knowledge is very much like iPhones, you know. Few medicines those were used in the past has been replaced by much safer, more individualized treatment, more advanced treatment, for example, in carcinoma, in diabetes, in asthma. So how do you get the knowledge? By attending the webinars, on-hand workshops, CMEs. The doctors can initiate this new line of healthcare in their clinics. We at IMA CGP headquarters organize the webinars also once a month. So I request the Keralam to please attend that webinar. Become member of CGP and also become the various branches of IMA CGP, for example, HBI portal, Social Security Scheme, PPF, and all these. You can join it by and be considered safe and updated from a team to deal with violence against doctors. Form a team to deal with the violence against doctors and donate generously for IMA Building Fund. That is your building, my dear friends, of IMA headquarters that we are going to rebuild in Delhi. So thank you for inviting me here and all the best to your program. Thank you.
Thanks a lot, ma'am. Now, let me proudly invite our great leader and past national president, Dr. A. Marthanda Pillai. He remains an inspiration for us in every moment. And hearty welcome, sir. Kindly address the gathering. Marthanda Pillai, sir. Sir, mute your hands.
Thank you, Prasanth. Let me at the outset itself congratulate you for taking this right initiative at the right time. Because nowadays, every day, we find the newspaper, the doctors are dragged in, rightly or wrongly, and for the wrong reason also. We always find a scapegoat in the government or the system and feel that you are perfect and you are right. But then the information gap that we have is huge. And to bridge that gap, programs like yours, weekly, that too ambitious program of weekly webinars, which definitely, if it is carried on further, it will be the best thing that we can do for the medical community. But I have a lot of confidence in you because as the president of IMA Trivandrum branch, for 1 year, you had similar initiatives, having webinars on socio-medical issues, and very successfully you have conducted it, and it was very popular also. The knowledge gap for a doctor is much more than what he imagined. At least 10 years or 15 years knowledge gap is there. Anything that is happening new comes to the textbook only after 5 years or sometimes 10 years. And that part to become a part of the curriculum for MBBS or post-graduation definitely takes another 5 years or more. So even when you think you are a fresh graduate and you are equipped with all the knowledge, your knowledge gap is at least 15 years. That's one has to realize. And to bridge this gap of 15 years of knowledge, there is no initiative from the government side. Because government is not conducting any CME programs or knowledge updation programs. And the sole responsibility IMA has taken on its own shoulders, and that too through the College of General Practitioners. And this is being continued now also. So that is one great thing that you are going to fulfill by starting these weekly webinars. And I'm sure that other topics which are not even the syllabus, like communication skill and soft skill development and other things also should be part of this program. Because we know that in olden days when we were house surgeons, interns, we spent our whole time, 24-hour internship in the hospital. Now with these NEET and PG entrance and all, students or interns are not spending the adequate time to learn soft skills in the hospital. And that is a great tragedy. But then it is a reality and it has to be fulfilled. And your initiative, which is a great initiative, and it is a great service, not only to the doctors, but to the community itself, should succeed. I am sure that it will succeed. I wish you all the best. Thank you.
Thank you very much, sir. Thank you very much. Dear friends, we are blessed with the presence of Dr. R.V. Ashokan, sir, the ever-inspiring icon of Indian Medical Association to everyone, like our beloved Marthandapilla, sir. And R.V. Ashokan, sir, was the past national president and past national secretary of our prestigious organization. Hearty welcome. Sir, kindly address the gathering. Dr. R.V. Ashokan, sir.
Thank you, Dr. Prasanth, for that very flattering words. Yes, our beloved President, Dr. Yaman Menu, National Vice President, Dr. Ramesh, our beloved Dean of the IMA CGP from Mumbai, a great leader on her own merit, Dr. Shobha Ahuja, our own inspiring leader. I don't know where from he gets the content for his speech, Dr. Marthandapillai. And every time it is fresh. It's so difficult to get a fresh message every time. And the viewpoints that he expressed in a couple of minutes are perhaps worth pondering. And respected leader, Dr. Babu Ravindran, Amita Karnanidhi, another woman leader from Tambram IMA, a great secretary. Our own state secretary, Dr. Rohit Chandran. And of course, your good self, Dr. Prasanth, and our ebullient Dr. Biju Nelson. I would like to make a mention of both of you, a great team for CGP. Prasanth, as Dr. Martanda Pillai sir said, during the COVID era, I remember it should have been COVID era and you were the president, and you lit that light in the darkness of ignorance, even among medical professionals. That light was lit by you. And I remember it went on up to 100 episodes or something. Yeah.
160,
or more.
sir. 160.
160. Yeah. It was a great marathon. I am sure you have one more year to go. So I am sure this is going to be a grand work from your side. You have been a president of Trivandrum branch, and the years of your editorship with Namada Aragyam are, star-studded. And your contribution during COVID and your excellent clinical work with the RCC. I also acknowledge your social dimension. And IMA headquarters actually made itself proud by awarding you the Doctors' Day Award last year. I think this has to be acknowledged here. And another star in the horizon of IMA Kerala State branch is Dr. Biju Nelson. I always have a lot of hope on him, the way that he conducts himself, the etiquette, the connect he has with the floor of the IMA. And he is from my own district. So both of you, I am sure with both of you in the chair, IMA CGP is going to go to a great height. I have a couple of information to be shared. The one is that I think it was 1992. Dr. Babu Ravindran should be remembering. I think Dr. Thomas Vaidyan was the president. It was so angry in the Central Working Committee. He said, why don't you wind up all these CGP and AMS, Thomas Vaidyan, firebrand. Biju should be laughing, right? And again, that followed from 94 to 97, the entire leadership, including Meladam Plasar, Marthandam, Thomas Vaidyan, and Babu Ravindran, made me the CGP secretary. I was CGP secretary for 3 years. And we were able to bring in the fellowship exams during that time. Oftentimes, people ask about the eligibility, about the legality of the fellowships. Fellowships are awarded by professional associations throughout the world. There are areas like fetal medicine and certain areas where the curriculum of the universities have still not reached and the NMC is perhaps blind to see. These professional associations have expanded the frontier. Like example, take the fetal medicine. It's a fellowship exam conducted by a professional association, creating specialists of extraordinary skill, which is benefiting the society. So like that, empowering every single MBBS doctor with skill is a great service. The fellowship can always be written in full words of fellowship, a fellow of. So I think the fellowship examinations also should be encouraged. I am sure you will be able to bring both of you as a great team. I have a lot of hopes. Revive IMA CGP to a level that we become the best. So all the best to the team, Dr. Prasanth and Dr. Biju Nelson. Thank you so much.
Thank you very much, sir. Dear friends, we are blessed with the presence of the National Secretary of IMA CGP, none other than Dr. Amuda Karunanidhi ma'am. She is so inspiring. On every call, she returns the right information at the right time with the right kind of motivation. Ma'am, we are extremely delighted to have your presence. Hearty welcome, ma'am, and kindly address the gathering.
Good evening, all. Respected National President, past National President Dr. Ashokan sir, Dr. Mataram Pillai sir, and the CGP Director of Studies, Kerala State Branch, Dr. Prasanth, and other dignitaries. Good evening, all. First, let us congratulate Dr. Prasanth for his active involvement in all the capacities. He is doing a very wonderful job. We congratulate the CGP director for starting this webinar series. It will be very useful for all the practitioners, for family physicians. Let us, we can update ourselves daily. There won't be any problem in it. As our Dr. Dean, Dr. Shobha told, we have to increase our CGP membership as well as the webinar series also. Once again, I congratulate sir. He is very active, sir. Even every week I will get some message from him, from Dr. Prasanth. Then and there I will also give the reply to him. We are going to host that. Kerala State is going to host this South Zone conference on 19th of this July. We are very pleased to come there. Myself and our dean will surely will participate, sir. Congratulate once again. Thank you so much for the opportunity given, sir.
Thank you very much, ma'am. Dear friends, we'll be finishing the inaugural session within a few minutes time. We have presence of eminent leaders of Indian Medical Association with us. Now we have another great inspiring leader of Indian Medical Association, Dr. T.N. Babu Ravindran sir, past National Vice President of Indian Medical Association. And apart from that, in every moment of need, he's there with all kind of inspiration and motivation. And hearty welcome, Dr. Babu Ravindran sir. Kindly address the gathering.
Yeah, Dr. Prasanth, Dr. Menon, and leaders and my dear friends. I too want to congratulate Dr. Prasanth for his very novel, enthusiastic idea of conducting this weekly webinars. That too with a very pertinent topic of clinical medicine, we're giving importance to the clinical medicine. Nowadays, we are slowly losing this charm of the clinical medicine, all going for sophisticated investigations and all. We remember our own good old teachers at that time telling the relevance of the clinical medicine and the bedside teaching. The history taking itself, if you take a proper history taking, the professional diagnosis about 60% you will arrive at that. And only supplement with your clinical examination, about 80-85% of the diagnosis there. And only if in doubt, we go for investigation during all those times. Nowadays, we subject the patient immediately for investigation. If a cardiac patient comes, immediately an echo is given. And if an abdominal pain comes, immediately a CT is given. So slowly the clinical relevance is losing. I'm extremely happy to see that Dr. Prasanth has understood the significance of that. And he is conducting a weekly webinar on importance to clinical medicine. And that too, he has brought the clinician par excellence, Dr. Padma Kumar, who is a well-known clinical clinician throughout the state. To inaugurate this meeting, I think Dr. Padma Kumar will be giving leadership to this and seeing that proper topics are selected properly. And extremely happy. When Prasanth starts with anything, he has got a Prasanth touch with it. That is, he do with all sincerity and continuity. And I'm extremely happy that whatever thing he has happened, starting from his Nammade Arogyam tenure and all those things, now I think his CGP also, he will be taking the CGP to greater heights, and our members will be greatly benefited by it. And I think Dr. Padma Kumar, equally a competent person, he make this webinar a very effective one. I wish Dr. Prasanth, we wish you all the best and wish this seminar all success. Thank you very much.
Thank you very much, sir. Our State Secretary, Dr. Roy R. Chandran, is on traveling. Is traveling right now. May I request his presence? Is Dr. Roy R. Chandran online right now? He will be addressing our gathering as soon as he is able to connect with us. Now, dear friends, let me invite and let me recognize the solid presence of great leaders of Indian Medical Association, including Dr. Alex Franklin sir, Dr. Srijit Kumar sir, Dr. Sulfian. There are eminent lot of leaders. There are many others to be, recognized, and their presence are truly inspiring. Representing all other great leaders of Indian Medical Association, may I humbly invite my personal motivator, always inspiring icon of Indian Medical Association for me, Dr. Srijit Kumar. Sir, kindly address the gathering.
I'll not take much, dear President, respected leaders of IMA. I'll just say one line. My medicine professor, Brigadier Kasturi, he used to say, listen, the patient is telling you the diagnosis. And let me quote Prasanth. In our last diabetes update, he told, don't be scared. The patient will speak only for 90 seconds. In fact, it was a huge eye-opener for me. From the next day onwards, I started listening, because when they start speaking, the first 10 seconds, we think that now they're going to speak for next 1 hour, which they don't. And then after he told, I also started practicing that, and I realized that they speak for 90 seconds or less. So I think if we listen for that 90 seconds, then the patient will tell you the diagnosis. And probably we have no other person other than one of the best clinician and one of the best orators the state knows, Dr. B. Padmakumar, to address this opening meeting. So I congratulate you. Let me just tell you one more line and stop. Now, the current ministry has come up with a famous phrase, health first, which in Malayalam translates to Adyam Arogyam. And the credit for this term actually goes to Dr. Prasanth. During the COVID time, he came up with this slogan, which the current Kerala government has accepted as their prime logo, which is Adyam Arogyam, which means health first. And before I wind up, I should congratulate the CGP team of Biju and Prasanth, whom I would like to call the smiling combo. You can never see them without a smile. And even if Prasanth's little distressed this time, Biju always smiles. So it's a great beginning. I wish the CGP team a brilliant session. And I'm sure all of us clinicians would learn and take back gems and pearls from this excellent session. All the very best to CGP, Prasanth, Biju, and all our leaders. Thank you very much.
Thank you very much, sir. Let us quickly go through, the IMA CGP, a few information from IMA CGP Kerala, and then we'll directly go to the academic session. Friends, we understand that today's limit has posed, entry of many people. From next Thursday onwards, we'll not have that problem too. And please understand that we have simultaneous YouTube stream going on. And so with this few words, let me heartily welcome all of you to the IMA CGP Kerala State program, and kindly follow the WhatsApp channel of Indian Medical Association Kerala's IMA CGP Kerala chapter with a link which is there in the in the chat box, which will be providing a lot of information and update. And today we have conceived an idea that is essentials of everyday in modern medicine, a weekly webinar series. And this starts from today, and every week we will handpick topic or a set of topic with a faculty or a panel of faculty, which will be extremely useful in our day-to-day clinical practice for sure. Kindly join and kindly share across the majority of the world, that I would say, because the medium of communication is in English, and we will definitely provide up-to-date information on the basics and review of basics for sure. Today, and kindly understand that you need not search for the ID or passcode or of the link, because the ID, passcode, or the Zoom link will remain same till 5th of November 2026 for sure. Same ID, same passcode, and same link. And you can also log in through our YouTube channel at IMA Kerala Official. Friends, history is very important. like the Park Community Medicine textbook told about the medical history and the individual patient's history, as everyone told. Now, the history taking in medicine, every people think that history taking is tremendous time consuming. Now we are with the Professor Dr. B. Padmakumar, a great orator, a leader par excellence, and a teacher, medical teacher par excellence of global standard, that I would say, former principal and HOD medicine. And he's a big writer. I cannot even count the number of books he has still, written in local Malayalam language as well as in English textbooks. So he's so passionate about learning, teaching, and spreading awareness, whether it is for the public or for the profession. Friends, let us wholeheartedly invite Professor Dr. B. Padmakumar, the former principal and HOD medicine and a great friend of Indian Medical Association, a leader of Indian Medical Association, for this prestigious session. Hearty welcome, Dr. Padmakumar, sir.
Thank you, Dr. Prasanth. Good evening, senior leaders of Indian Medical Association. Dr. Prasanth is the director of CGP IMA, and other senior members of IMA CGP, dear friends and colleagues. First of all, I am thankful to my dear friend Dr. Prasanth for the kind introduction, as well as giving me the opportunity to start the important webinar, a series of webinar for the coming few months. And I came to know that I am the first person to start the program. That is also a great appreciation and honor for me. And I remember during the COVID times, if I am right, it was during May 2021, Dr. Prasanth initiated a great program, Arogya Manandam. As Dr. Srijit has rightly pointed out, the same title was accepted by the government of Kerala also for their cancer screening program, Arogya Manandam. And it was a series of 100 days program, followed by a 60 weeks continuation of the same program was also done. And I am happy that I was also the part of the program. And I remember it was a very useful activity during that COVID time, discussing various aspects of the COVID. I hope that this program also will be of the same standard for updating the general practitioners regarding the various health topics of current times. As we all know, general practitioners are the backbones of our primary medical care, and their contribution to the Kerala model of health is also really commendable. And I would like to congratulate IMA for supporting these general practitioners by conducting various CME programs as well as certificate courses also for updating regarding the various changes as well as new developments in the medical practice. Today's topic is very important, as many of the senior leaders have rightly pointed out. History taking is one of the most important pillar in making the diagnosis of various medical conditions. I am speaking from Alleppey. Here it is heavy rain in Alleppey. Because of the range problem, I could not join from my laptop. Kindly bear with the inconvenience, and Dr. Prasanth will change the slides for me as when I am asking him or directing him. So regarding the topic proper, the history taking is very important, and it is having a very important role in making a diagnosis, whether it is a medical student or whether it is a senior professor or whether it is a general practitioner. In all aspects of or in all sections of our medical fraternity, the history taking is very important because of mainly 4 important points, we can say. One important point is that it is directing, most important aspect is that regarding the investigations, how to plan the various investigations. It will help us to formulate various the investigations, plan the investigations. A proper history will help us to plan the investigations. And also it discusses various non-biochemical factors like occupational aspects as well as environmental aspects. Such aspects also will be discussed during the history. And also it help us to manage the patient treatment aspect also. Sometimes the history will be helping us to discuss regarding the drug allergies, drug interactions, etc. So that is also very important. And finally, it makes a strong bond between the clinician or general practitioner or the professor and the patient. So it is an important exercise by which we can initiate the patient interaction, and it will be helpful for us in making a correct diagnosis. Before going to the topic proper, I would like to discuss few real case scenarios. The first one is a polyarthralgia patient. Came to me actually. Is a 47-year-old teacher with a polyarthralgia of 2 months duration. She had early morning stiffness also of 20 minutes, and the rheumatoid factor was positive. And a diagnosis of seropositive rheumatoid arthritis was made by one of the junior faculty in my unit. And that patient was put on NSAID, steroids, and methotrexate also. It is a drug of choice in rheumatoid arthritis, as we all know. But there was no improvement, and her diabetic status actually worsened. So when retrospectively asking the past history, we would like to hear that she is a chronic diabetic patient for the last 10, 15 years. And her actual problem was actually a limited joint mobility, known as the chiroarthropathy. That is the commonest rheumatological manifestation in diabetes patient. So without knowing that the patient is a chronic diabetic patient, because of the lack of proper past history, she was unscientifically put on various disease-modifying agents. The second case really is a known-to-me person, a 67-year-old chartered accountant person. He is an hypertensive and diabetes also. He came to me for the evaluation of the pedal edema for 4 weeks duration. But unfortunately, I could not take the past history and drug history properly. That edema was a drug-induced edema because of the amlodipine. We all know this amlodipine dilates the arterioles and doesn't dilate the venules. And because of the this dissimilarity, there is an increase in the pressure in the capillaries, and that leads to the development of edema. That is there in about 60% of the patients with amlodipine. I again evaluated the patient unnecessarily for a lot of other conditions, but finally I came to know that it is only because of the drug that patient is using, and drug was the reason, and proper drug history was giving the answer. Another person with a cough of 3 months duration, and 3 months duration, is a 36-year-old medical representative. And the patient presented with a dry cough, and the patient was a recently detected hypertensive also. The past history and the drug history, we came to know that the patient is using AC inhibitors. And as we all know this nowadays, AC inhibitors block the breakdown of bradykinin as well as substance P. Both can produce cough, and that was the reason for the cough of long duration. Next slide, please, Prasanth. Next slide. Okay. Again, another patient with a high serum uric acid, and the serum uric acid was more than 7. And directly, the clinician started the patient on a urate lowering treatment, that is pebisostat. But the proper history later taken showed that the patient had a psoriatic lesion, extensive psoriasis. Next slide, please. Extensive psoriasis, and that psoriasis led to rapid cell turnover, and that was the reason for the high uric acid, and there was no need of any urate lowering treatment in this patient. So all these real case scenarios shows the importance of a proper drug history, a proper past history, as well as a evaluation of other important aspects of the personal aspects of the patient. So with this, we will go to the topic proper. As Dr. Srijit has already pointed out, history taking is an art. Actually, it increases the bond between the patient as well as between the clinician, and also it is considered as an art by which we can interact with the patient properly. Next slide, please. As the great medical teacher William Mosler has pointed out, listen to the patient. They will tell you the diagnosis. That is very important. We have to be patient, and with the patients, we have to hear to the details of the patient, and then they will, most of the time, if the patient is having a reasonable educational status also, they will definitely tell you the diagnosis. That was the comment by the great medical teacher, William Osler. And he also mentioned that medicine is learned by the bedside and not in the classroom. So a bedside discussion, nowadays it is coming down, unfortunately. That is most important aspect of making a clinical diagnosis. It is especially important for medical students. Now, as already mentioned by the great leaders here, the 70% of the diagnosis in any case, whether it is a PUO or whether it is an arthritis of unknown origin or whatever it may be, or it is a chest pain, etc., 70% of the diagnosis is made by not by sophisticated investigations or examination. 70% of the diagnosis is made by history alone. So that is the importance of history in most of the clinical conditions. Next slide. So there are certain rules to observe while we are taking the history. We have to be clear, and we have to be more careful in how to take the proper history. There are certain rules to observe. You will see. Most important is that, next slide, listen to the patient. To hear, just to hear is not enough. So we have to be, it's a time-taking procedure, and we have to be careful, and we have to be sincere to the patient, and we have to hear to the patient. Not only just hearing is important, but listening is very important. So we have to be careful and sincere in taking the history. And next important thing is that it should be a confidential matter, especially when we are dealing with the personal aspects of the patient, then sexual history of the patient, and socioeconomic aspects of the patient, etc., and drug history of the patient, etc. We have to be confidential. I remember several times when young persons come to us with their parents, they are reluctant to disclose many of their sexual history and their extramarital contacts, etc. So we had to be confident. We had to keep a confidential atmosphere while we are dealing with the history, especially when we are dealing with the younger persons. That is also another rule to observe while taking the history. Next slide. And there should not be any interference or interruption. That is also very important. The patient should be allowed to tell the history in his own words. That is also very important. Unless he rambles or digresses from issues at hand, when he is moving away from the real aspect. Otherwise, there should not be any interference or interruption. And most important aspect is there should not be any leading questions. Next slide. There should not be any leading questions. Whenever he is starting telling something regarding the chest pain, we should not then ask a leading question. It is radiating to the left upper limb, or whether it is radiating to the interscapular area or to the back or to the jaw, etc. Such things should not be happen. Most of the time the patient will say, always better to avoid such leading questions. We should allow the patient to say his own story in his own words without any interruption. That is another important rule to observe. And next slide. Avoid patient statements, but at the same time, we should avoid, or we should not allow the patient to say like this: I am having an ulcer on the stomach, or I am having a chest pain, maybe due to myocardial infarction, or I am having vertigo, maybe due to hypertension. Such statements better to avoid, and we should not encourage such statements. We should ask the patient, let us discuss the real problems of you. You tell me your problems, not the diagnosis, probable diagnosis. You tell me what is your exact problem. Whenever is the occurrence of vertigo is increasing, whether it is related to the positional change, etc. So patients' statements, diagnosis, etc. have to be discouraged. These are the important rules which we had to observe. Next slide, please. Then initially, because it is a strong bond between the patient as well as the doctor, so we had to introduce ourselves. Always be obliged to the patient. We had to respect his personal aspects also. So we had to introduce ourselves. And always another important aspect is that we had to take the consent, especially it is important in the hospital. Whenever the patient is surrounded by a lot of bystanders or the relatives, we have to take the consent of the most important relative. We are going discuss some problem of your father with us. So kindly give us the consent. That is also very important. And patient should be seated. His personality should be should be definitely respected. The slide. Patient's own descriptions of symptoms are recorded. So his own descriptions, if he is narrating the chest pain and his own words and his symptoms in his story without any interruption have to be recorded in the case sheet. Next slide. Every symptom is thoroughly analyzed. That is again another important thing. The most important aspects to be discussed are one is the onset of the problem. For example, the patient is coming with the cough. If there is a immediate or acute onset of the cough, usually it denotes the possibility of a foreign body aspiration. The duration is also important. We know the acute, subacute as well as chronic cough. If the cough is of more than 8 weeks duration, it denotes the possibility of a chronic cough. Then character of the cough is also again important, dry cough or productive cough. Severity, whether it is associated with the severe manifestations like cough, syncope, etc. And behavior of the symptom. For example, the chest pain. Chest pain is aggravated by taking some exertion or relieved by rest. So all these minute points we have to thoroughly analyze before going to the next symptom. The slide. The important points, these are all familiar to us. I am not saying anything new to you. All these are familiar to us during our undergraduate days as well as the postgraduate days. We will take the presenting complaints initially, and following that, we will take a history of the presenting illness also we will take. Then past history and personal history are very important. This is the order. Then we will take a treatment history, a very important history. Menstrual history also very important. Then occupational history, because we would like to know whether the patient is having an occupational hazard. So we'll take an occupational history in a systematic way. And finally, we will conclude by knowing the socio-economic status of the person also. These are the points which we have to interfere while we are taking the history in a periodic way. Next slide, please. Of course, we have to take the biodata of the person, a name for identification. Age is also very important. For example, a 20-year-old man, a young man coming with a knee pain, maybe because of the trauma. At the same time, a 60 or 70-year-old man coming with knee pain, knee joint pain, probably maybe due to osteoarthritis like that. So the age of the person is also very important. Basic things address as well as gender, because gender, certain diseases are more common, much more common in younger females. For example, a young female coming with PUO. We have to consider the possibility of a SLE. At the same time, a 75-year-old man coming with the PUO. We have to definitely consider malignancy also, non-infectious causes of the fever. So the gender, age, everything is very important. Next slide. Presenting complaints. That is the first and foremost aspect of taking the history, whether it is in our consultation room or whether it is in the ward. This is very important. Complaint for which the patient came to us. That is the presenting complaint. For example, patient came with a chest pain of 2 days duration. Then that complaint we had to narrate while discussing the presenting complaint in patient's own words, and there should not be any leading questions as already we discussed, and should be discussed in a chronological order with duration. That is also very important. For example, patient coming with pneumonitis will have symptoms like fever of 2 weeks duration, then cough of 1 week duration, and a chest pain of 3 days duration. That will be the chronological order with which we had to note these symptoms in our case sheet or in our records. Next slide, please. Then the history of the present illness. Again, this is another important aspect where we had to expand and we had to know the details of each and every aspect of this present illness. For example, chest pain, the mode of onset, whether it is acute, subacute, or insidious. An acute onset of the chest pain can be due to pneumothorax or pulmonary embolism or myocardial infarction, or an insidious onset of chest pain can be a muscular pain. The duration of the pain is also important. Location, the character is very important. Pricking type of the pain, or it is like a heavy pain, or the intensity of the pain. How severe is the pain? The chest pain is so severe that I could not move even a single step. denotes that the pain is very severe and it denotes a possibility of a serious condition. Then behavior of the pain, whether it is related to activities, aggravating and relieving factors, very, very important. For any symptom, especially for pain, this this point is very important. Aggravated by activity or aggravated by lying down, breathlessness, aggravated by lying down and relieved by sitting up. So all these symptoms aggravated and relieved by certain factors. These are very important in making the history. And also we have to know the associated symptoms, whether the cough is associated with hemoptysis or purulent expectoration or halitosis, etc. So associated symptoms also we have to ask. Chest pain, if it is associated with the palpitation or chest pain associated with the syncopal attacks. All these are denoting the possibility of or suggesting the possibility of various conditions. Then finally, we had to know the course of the illness. When the chest pain started, it was very severe. But nowadays, I am getting a relief after 1 week or 7 days or 2 weeks. That shows the possibility of a relief to the patient. This is especially important when a person comes with a hemiplegia-like problem. At the time of the presentation, the power was grade 0 only. But at the time of examination after 2 weeks, the power is almost grade 4 or grade 5. Shows the possibility of the improvement. So this slide is very important. History of the present illness. We have to take in detail, considering the possible differential diagnosis, we had to take a detailed history of the present illness. In between, we can ask some leading questions also, but always the patient should be allowed to say patient's own complaints in his own words. That is also very important. Next slide, please. Now come to the past history. Again, rheumatic fever, hypertension, diabetes, ischemic heart disease, CVA, CO, all these medical comorbidities we had to ask. And COVID is again very important history that we had to take nowadays, because COVID can produce a lot of long COVID manifestations in the form of brain fog or fatigability or respiratory symptoms, shortness of breath, etc. So history of COVID, especially severe COVID, category C like COVID also we had to ask in the past history. Of course, history of travel to other state, usually during our undergraduate days, any patient with fever, rigor and chills, we used to ask them, is there any history of travel to North India? But nowadays we are also getting indigenous or in-state cases of malaria. But previously it was not like that. You used to ask them the history of travel to other states, especially North State, whenever the patient comes with a prolonged fever. Next slide, please. Next slide. Prasanth, next slide, please. After the personal history, we had to take the
sir, next.
Next slide, yes.
Okay.
But, no, before that. Before. Yeah, yes, thank you. This is family history is also important. Health status of the parents, siblings, spouse, and children, because we know this young age myocardial infarction, if it's occurring in the first degree relative, like in the parents or in the siblings or the children, that is also a risk factor for developing a vascular accident. Similarly, history of consanguinity, again, history of any, to rule out the possibility of a genetic condition, history of consanguinity, history of similar illness in the past also, to know whether it is a chronic condition, then history of communicable diseases in the family, for example, tuberculosis or Hansen's disease also is nowadays we are getting cases. So such history of communicable diseases in the family also, we have to ask while taking the family history. Next slide, please. Now the personal history, smoking, again, pack years, number of packets smoked per day into number of smoking years gives the pack years. The significance is that if it is more than 20, it shows the possibility of or denotes the possibility of a high chance of bronchogenic carcinoma. Of course, we have to take the history of alcoholism, tobacco, chewing, drug abuse, etc. also. The personal history also, the sleep, appetite, and bowel and bladder habits are also very important. All these are well-known facts, but we have to be careful while taking this history also. Now comes the most important history, as we already discussed during the initial slides, initial parts of the presentation. Drug history is very, very important, especially many of these symptoms. Prasanth, next slide. Yes, treatment history is very important. Drug use, especially as we already discussed, amlodipine producing edema or AC inhibitors producing cough. Then drug allergy also is very important. Fixed drug eruptions can occur in a patient, and that may be chronic also. So another important aspect, especially in our state, is the use of indigenous medications. Patient is coming with renal or hepatic conditions. There is a transaminitis, elevation of the SUT, SUPT, etc. Then the history of any indigenous medication use also, that also very important while taking the treatment history. So this treatment history also we have to take in detail. And of course, especially next slide. In females, you have to take the menstrual and obstetric history. There is history of recurrent abortions. I am giving an example. History of recurrent abortions in a young female with the polyarthralgia. You have to rule out the possibility of an antiphospholipid antibody syndrome, and especially the recurrent these abortions occur in the first trimester of the pregnancy period, and also the person is coming with the symptoms of hot flushes, etc. This history of menopause also we had to take, and especially females coming with hyperuricemia. After menopause, there is high chance of developing gout in females also. So menstrual history also very important in females while taking the history. And of course, occupational history. Next slide. Occupational history also. Occupational hazards. We know many of the conditions, especially lung diseases, occurring because of the occupational exposure to harmful poisonous gases, dust, fumes, etc. So occupational history. The symptoms are aggravated while I am going to the factory or to the workplace and got relief during my holidays. It's a typical history of an occupational hazard. And exposure to dust and chemicals also we had to take. Now, this is the next slide. This is my last slide. Socioeconomic status of the person is also very important, because overnutrition, this is also considered as a similar to this undernutrition. Overnutrition is also considered as a possibility of a malnutrition actually. Overnutrition is also malnutrition. So poverty is very important. Literacy is very important. Nutrition is also very important. So the socioeconomic background of the person also we have to take. For example, the person is coming with anemia, and if it is an affluent person, maybe because of the excess consumption of the fast food or the junk food. But if it is in the lower socioeconomic status, maybe because of the poverty. So the socioeconomic status of the person is also very important while taking the history. So next slide. Next slide, please. Prasanth, next slide. Okay. That was my last slide, and with this few comments, I would like to conclude my presentation. So, as already we all discussed in the very beginning, history taking is very important in medical diagnosis as well as in the evaluation of the patient. It is one of the three important pillars of our diagnosis. The three pillars are history taking, then clinical examination, as well as the various investigations. So among these three pillars, history taking itself, in most of the conditions, we will give a diagnosis of possibility of a 70%. So my professor in Hyderabad used to tell me, see Dr. Kumar, after taking a detailed history of the patient's rheumatological manifestations regarding the joint pain and other symptoms, etc., after hearing the history for about 30 minutes, if you are not coming to a conclusion, it is unlikely that you will get a diagnosis after the examination or investigation. That was his comment. I think in many of us also will be having the same experience. Most of the time, whenever patient comes to us after hearing the story, in most of the condition, we will be able to come to a diagnosis. If it is not possible, it is unlikely that we will reach a diagnosis by examination or by investigations. With these few words, I am concluding my session. Once again, I am thankful to all the listeners as well as to my dear friend, Dr. Prasanth, for giving me this opportunity. Thank you, Dr. Prasanth.
Thank you very much, sir. Dear Padmakumar sir, you have elaborated the extremely important topic of general medicine and particularly general practice in our day-to-day life. Sir, now we have a few minutes left for some question and answer session. Let us have any question. Let us check for any questions from the audience side. Dear friends, it is your time. Please ask questions that are common and relevant to the general practice and particularly focusing on history taking. You can unmute and say briefly, or you can share your questions in the chat box. So there is a question in my personal chat box.
Yes, please.
So the question is that nowadays, in majority of the hospitals, there are some people, especially nurse practitioners or nurses, taking the history, and the patient comes in front of you with the history already taken, and there is a huge array of investigations there. In that era, in the BCOP, do the doctor need to take a history again? Is it clinically relevant in the context of this present world?
Yeah, that is a very important question because certain things cannot be replaced by nursing staff or our co-workers. Of course, the hospital may be having that pattern of evaluation. Let it be there. But at the same time, we had to develop a strong bond between the patient as well as between us. So for making that bond as well as for our own professional satisfaction, we have to take our own history. That is very important because as already we discussed several times, without getting an idea after the history, it is unlikely that we will reach a point by investigations or by examination. So always better to take history by our own effort and our own time we had to spend for taking the history. Let it be there, nursing staff history or other health workers, let them take. But we have to take our own efforts to extract maximum points from the patient.
Thank you very much, sir. Actually, in fact, today evening I was discussing with our former professor, Dr. Bhasi sir. Bhasi sir was telling, he was also narrating the same thing. And in the history taking, there were numerous errors in, reaching clinical diagnosis when we depend on the staff, because they will be doing it because they are not following up the patient. We are the guardians of the patient. And as modern medicine fellows, we all need to, keep up our professional ethics, and we must follow what we owe to the patient and the patient owe to us. And it is a very big relation. And that is a message from the College of General Practitioners side too. Thank you very much, sir. And meanwhile, let me announce that the next week's session will be on approach or other management of short fever, which is of utmost importance in this season too. And that will be presented by none other than our beloved Professor Bhasi sir, the doctor, the Professor Emeritus of General Medicine, our Sri Gokulam Medical College and Research Foundation, and a teacher of many of us. And so let us meet on that next Thursday at 8 p.m. sharp, and we'll arrange more seats in the Zoom so that everyone can attend the Zoom itself. And if there is no more doubts, because the Padmakumar sir has presented the topic in such a way that it there is no space for even a doubt, but still there are, I know there are people who may be a bit hesitant, but we have 30 seconds left if you wish to ask another question.
Prasanth, good evening. Hello.
Please, sir, ask in English, sir, please.
I want to, there's excellent presentation from Padmakumar sir. I want to highlight one or two points. So many times we communicate through history through phone. That is very common now. Hearing the history through the phone from the patient, and we prescribe some medication. So finally, what happens is we may mistake some diagnosis. We mistake our diagnosis because we are not seeing the patient, and mostly we prescribe medication through phone. which I think it is. I had a personal problem a few months back. The same thing. The patient had a chest pain, not chest pain, for a shoulder pain, and she attributed that to lifting a weight or some ulukavati. That was the word she told. So I just through phone I asked them to take some NSAID. Finally, after 1 week, not subsiding pain, not subsiding, she came to me. We just took an ECG because the pain was not subsiding. So we took an ECG. It was MI. So we missed a diagnosis of MI because just treating the symptoms over phone. So that is one thing I want to highlight. Another point is when you write prescription, it should be legible. May not be related to this topic. What happened was one patient was prescribed Actiferon for anemia, but the patient was getting Acitron instead of Actiferon. So because it was not legible, Actiferon was not legibly written, so the pharmacist gave Acitron, which is an anticoagulant. So such things can happen. So these are 1 or 2 points from my clinical experience. I'm not a clinician per se, I'm an anesthetist, but I see some cases, I have witnessed some cases like this. So please, for the benefit of others, viewers or benefit of other observers, I am telling this. Okay, thank you,
sir. Thank you, sir. Padma sir, there is a question. What is the importance of collateral information and what to do if the patient and bystander gives conflicting history?
Yeah, again, that is another practical issue. But I think if an intelligent patient is sufficiently intelligent, then that there will not be much problem. But we have to gain some information from this collateral information also, if it is reliable. For example, some patients are undergoing treatment from other places in North India, from All India Institute of Medical Science or from other institutes, and they are coming to Kerala for their vacation, and they are coming to us. Then they will give some diagnosis that was there from their institution in North India. Sometimes it will be useful to make a certain diagnosis, but always we have to depend upon their records. If they have proper records with them, then we have to cross-check that records. Then only we have to rely on this collateral information. And also the bystanders. Sometimes the bystanders may be very intelligent. They also may be giving some proper information, especially in elderly person. Elderly person, because of the memory problem, they may not be narrating the story in a proper way. In that case, the caregiver, maybe the daughter or the son, they can help us to fill the gaps. That is there. So these are few conditions or few occasions where this collateral information as well as the information from the bystander will be useful. Otherwise, always depend upon the patient itself for a proper and complete history. Thank you very much, sir. Actually, hearing you, I am reminded of a problem. Like, nowadays, the era of insurance, there are certain insurances where if you are termed previous history of alcoholism, they may not get the insurance. And so in such situation, our patients may not, tell you their history of taking alcohol or history of smoking, something like that. So always let us leave confidence. Give enough confidence to the patient and the bystander so that, the information, which you gather as part of clinical practice will not be shared to your, whatever, in whichever way that might harm them. And let me also tell you the Medicep and all those kind of insurance in Kerala, they had some problem with the, past history of alcohol in RCC and all, we saw it. But nowadays, the claims are not cancelled just because there is a previous history of alcoholism. So there is actually, that was a false information. So especially the habits, which may be very important in getting into a clinical diagnosis, in many situations. Friends, actually, Dr. Professor B. Padma sir, as I told you in the beginning, he's a great friend of Indian Medical Association, a big leader of Indian Medical Association, and as well as a great leader of the profession as a teacher par excellence and a writer par excellence. We do not have words to thank him because he was in just a busy moment after his immediate superannuation. He was so busy, but he immediately accepted our invitation because we wanted a person like him
to start the ball, rather the kick the ball rolling. And we are so delighted and grateful to Professor B. Padmakumar sir. Thank you very much on behalf of Indian Medical Association, IMA Kerala College of General Practitioners, and all the, the people who were listening through the Zoom and through the YouTube channel. Thank you very much, sir.
Thank you, Prasanth. Good night also.
Good night. And dear friends, without you, the College of General Practitioners or Indian Medical Association is not there. Kindly spread the word about this initiative and bless us with your presence in every Thursday without any hesitation, because it is the knowledge and the wisdom that is actually it is going to take our to a greater heights. Not only ourselves, but to the clinical practice. The nation is desperately looking forward for great doctors to face challenges in medicine and public health. Be there in the right moment with the right wisdom and in your full strength. Greetings from Indian Medical Association, College of General Practitioners. Thank you all. Wishing you all a great good night. Thank you. See you next Thursday, 8 p.m.